Hi folks, this is Dr. Rob Cywes. I am the CarbAddictionDoc. And today I'm going to talk about depression. Depression. I'm not a psychiatrist, I'm not a psychologist. I'm just someone who spent years and years in the clinical trenches and seen more and more anxiety and depression. And folks, I've been a bit of an arsehole about depression for a long time. I've had bouts of it, but I've never really suffered from it. And even though I'm a doctor, even though I try to be as empathetic as I can be, I know as I look at myself in the mirror, I've been a bit of an arsehole about recognizing and understanding depression. And I'm not going to talk about depression from a psychological, from a psychiatric perspective. Don't think of me as a psychiatrist, I'm not. These are just observations. But as I look at my patient population, it is incredibly common to see people suffer the ravages of this awful disease. And so the way I've looked at it, I've stepped back and I've realized that there really are two completely separate, they overlap, but two completely separated forms of depression, maybe three. The first form is very common, and all of us suffer from it from time to time. All of us interact with life that causes us to become depressed. Every day, all people experience things that cause a minor degree of depression. And ultimately, what getting out of that minor, I call it reactive depression, where you just feel a little bit down about something that happened to you. Life throws something at you. You're in a state of mind where you may be exhausted, you may be tired, you may not have great coping skills, and you react to what life is doing to you with what's something we call reactive depression. And everybody, the happiest person gets depressed from time to time. But when it comes to reactive depression, and that's all I'm going to talk about right now, I'll talk about the other form of depression in a little bit. But with reactive depression, it comes down to three things if you really want to treat it effectively. Number one, the more you can learn to take your emotional pulse on a regular basis each day, the more you're going to recognize it when it's beginning to come at you. And the further you can be ahead of it, the more you can understand, okay, this thing that's about to happen may cause me some depression. Here's what I'm going to do about it. And one of the things you've heard me talk about is a bridge. Now, this is my coffee. Yeah, it gives me a little bit of hydration, but the main reason I'm sipping on this coffee is as a mind-cleansing moment. It gives me a moment to step back from the rock face of my life, to take my emotional pulse, and to look at what it is that I'm doing and what's happening in my life. And over time, I've trained myself, and it takes a long, long time. I'm still in the process. I'm certainly not there yet, to recognize things that may be getting me a little bit down. And if I can look at them over here and see them instead of having them bubbling up inside of me already, I can say, hey, depression, I see you. And if I then look into my emotion management toolkit, and I've developed and practiced over time and created in my own life as a foundational element what I call an effort-based emotion management system, physical activity, a creative art, spirituality, meditation, or empathetic human connection, I can say, I see you, thing that's going to make me depressed or thing that's getting me down. I'm going to take my dog for a walk. I'm going to go and chat with my wife. I'm going to put on some music to uplift me. If I can recognize my reactive depression and use one of my tools to help me through it, I can nip that in the bud. I have that little dip, but I've got a ladder that I can climb out of the hole of depression. I look at depression as being this hole that we fall into from time to time. But if I've got a ladder and I've got the skills to be able to climb out of that hole, then I don't stay in that hole for very long. That's reactive depression. There are a lot of people that I see that don't have an effort-based emotion management system. They don't even recognize that they are depressed. Most people don't recognize it. Somebody else has to recognize it on their behalf. And those people either use medications to stabilize themselves, but they remain in the hole, or they use substances or drugs to get them high. But getting high is not dealing with depression, it's just masking it. And they stay in a constant state of reactive depression that they don't need to be on, because that reactive depression is entirely behavioral. It's how we deal with our lives. And I'm not underscoring it, but I'm saying that it's ideally treated by personal therapy, by using tools and skills and people to get you out of the hole. Can you leap out of the hole? Sometimes. Most of the time, it's gradually climbing out. But in order to do that, you have to recognize it, identify it, name it objectively, and say, hey, dude, here's how I'm going to deal with you. That's the common and garden, I'm not underscoring it, reactive depression. And I understood that and I knew that, and I've been pretty good about helping people to deal with that. But here's something where I was a bit of an asshole because I didn't understand this. I didn't understand this. And I'm not going to say this, I'm saying what I'm going to say now, not in a sexist way, but more from a medical perspective. It's by far more common in women, but it occurs in men too. And that is major depression. Major depression is a biochemical and hormonal disorder. And of course, biologically, women's hormones are different. I'm not saying they're worse. Please don't take that as a sexist comment. But major depression is a biochemical depression. It's not a reactive depression. And I never, ever really paid enough homage to it because I've never suffered from it. Now, folks, you want to make that distinction. But major depression happens. It's like when you're walking down the road by yourself, quietly minding your business, and someone jumps out and clubs you over the head with a baseball bat. That's major depression. And it is an awful, awful, awful state. Very commonly associated with anxiety and often associated or as part of bipolar disease, 1 or 2. Usually 1, I think, is the depressive. I'm not a psychiatrist or a psychologist, but I believe it's bipolar 1. And that is where you just biochemically flatten out. And it's an awful, awful place to be. And the standard routine behavioral therapy does not work. And the reason I focus on the females where you're pre or postmenopausal, it is critically important to manage your hormonal milieu first. If you're premenopausal, even if it's using birth control or finding a hormonal regimen that helps you, it definitely requires some of the psychiatric drugs, the SSRIs, the monoamine oxidase inhibitors, the antidepressants, and maybe even the anxiolytics. That is where drug therapy is the starting point, whether it's hormonal therapy or brain chemistry drug therapy. That's the starting point. But even major depression is not a lifelong sentence. We can recover from it. But that's where I've been remiss in terms of advocating behavioral therapy as a primary treatment. That's out of my hands. It really requires a psychiatrist to use medications. Now, here's the type of psychiatrist I'm looking for. Number 1, to make sure and confirm that the diagnosis is major depression. Number 2 is to use as few drugs as you need to treat the depression. There are certain drugs that I've observationally seen my patients on. For example, Cymbalta is one of them. It may have a lot of value, but my God, it is an awful, awful, often life sentence. So use that as a last resort. It may be a very powerful drug, and if someone needs saving, use it. But don't use it if there are other drugs that can help you to get out of the hole equally well, that you can eventually potentially come off. I'm not saying you have to come off your medications, but at least give people that hope. Because if we can restore the biochemistry, there is a chance you can recover. Yes, the behavioral part developing the behavioral skills is a piece of it, but it's a fraction of treating major depression. And I think as healthcare workers, as practitioners, we have to be able to recognize the distinction. Even though I'm not a psychiatrist, more and more I've become attuned to this. Now, having said that, I see it more visibly and more clearly in my female patients. The most difficult people to diagnose, the most difficult ones are the men with major depression. Because even though our society is becoming more egalitarian, there's still pressures that are put on a lot of men to just suck it up, to just deal with it. And very often we don't realize that those men have major depression as a disease, and nobody is out there to give them that lifeline. I'm not an expert in this, folks. I'm just beginning to explore this. But as I look at this process, I look at reactive depression from being different from major. Reactive needs therapy and better emotion management skills. But major depression is a biochemical disorder. It needs people like myself to be aware of it, to diagnose it. It has a fundamental hormonal, both whole body and brain hormonal background to it. It is unexpected, it is not necessarily situational. And it needs primarily to be treated with recognition, medication, and then observation to see if you can correct that hormonal milieu. And the sad part, folks, is in this era where we have condemned the heroin users and the benzodiazepine users, and we doctors are unable now to adequately prescribe those medications. That has become a real travesty, because more and more people are obviously suffering from major depression, and our tools are being limited, and the treatment that is being prescribed to these folks is not necessarily being done by people that understand the process. I don't understand that process completely. So I can help people to understand that they have the problem, but I'm not the guy that should be treating it. In fact, I've got a couple of people, psychiatrists, that I'll send them to for evaluation and management. But don't use the blunderbuss approach. Approach major depression as something that patients can recover from. It's not necessarily a life sentence. Can stabilize them, and use as little medication as you need to, as you can, to get them up. Polypharmacy. I've seen people come in on 10 and 12 different drugs, and then they're being treated for side effects of drugs with other drugs that have other side effects. It's a very, very, very tough disease to understand, to recognize, and to treat, and to differentiate. I know I didn't give you a lot of answers. I know that I don't have solutions for everything, but I have some insights. And I apologize to anybody where in my past life I blew off major depression by calling it reactive depression. It's not about pulling up your pants and sucking it up, whether you're male or female. It really is about distinguishing this as an organic disease process that needs to be treated chemically, biochemically, and possibly with therapy. I've become compassionate about this disease. I'm certainly not claiming any skills in treating it, but hopefully my insights will help other healthcare practitioners to be more sensitive to, more aware of it, and not just to write those people off. If you do suffer from it, get your diagnosis made and go to somebody who doesn't see it as a bad disorder. People that are judgmental of fat people shouldn't be working with fat people. People who are judgmental of depressed people should not be working with depressed people. if we are empathetic to your needs as people who work in this arena, we are best able to help you. Good luck, and I hope this gives you hope. I am the CarbAddictionDoc. That's what I do. I don't treat major depression, but hopefully I can recognize it more often and point you in that direction. Thank you.